So, I'm going to introduce. Hi, very good morning to everyone. I hope all of you have enjoyed your weekend. So once the weekend is over, we're back to the grind. So we're back with the clinical skills session which we had last week. I hope you really like them and you learn from them. So in continuation with the series of the sessions, we're going to continue today with our sessions on skills in obstetric and gynecology. And it's a big honor to have Professor Mawahib with us. Dr. Mawahib, please welcome for this session. I'm really very happy and proud that you have come out of your clinical workload and trying to train our children so that they have enough skills so that they're confident when they come to you for a clerkship posting, they know exactly how to do and how to go about it. Thank you very much, Dr. Ma'am, for coming. And the floor is open to you. And she's going to discuss to you about what the important aspects of issue taking in obstetrics and how do you do a obstetric examinations. Following which will be broken into the groups and you will be practicing those skills along with our clinical tutors who are also with me, smiling behind the mask. Right? Thank you very much, ma'am. And the floor is open to you. Yeah. Bye-bye.
Thank you. Thank you, sir. Thank you very much for this introduction. I am Dr. Mawahib. Thank you for attendance for this session. It is of my pleasure to start with this important topic for the obstetric history. Of course, there is obstetric history and gynecological history. The obstetric history will involve the history involving with the pregnant ladies and after deliveries. The gynecological history involve the gynecological problems, and it will be discussed in other topics, in other sessions. Why we should take the obstetric history? It is an important part of the management of each case to start with the history. Of course, we don't know the patient is pregnant or not. We have a patient in the reproductive age group. So how to start management for this patient? Any patient who come to us, how to start management? The management usually starts with the history. There are certain points to be taken in the history for each patient. And before taking the history, you should introduce yourself to the patient, so she will be more confident. So introduce yourself and start asking the patient these following questions. For example, what's your name? How old you are? The age of the patient, because there are certain obstetric problems common to certain age group. Nationality of the patient. Why nationality is important? Because there are some diseases may be associated with ethnic variation, such as sickle cell anemia or some problems more in some groups. And the occupation of the patient, so that because certain types of work, heavy work, for example, may affect the pregnant lady. So after this introduction, we have to start the patient, what's your problem now? The chief complaint. The chief complaint in obstetrics, and in obstetrics specifically, either the patient has no complaint, she just came for antenatal care or for antenatal checkup, or there are certain problems like vaginal bleeding, abdominal pain, reduced fetal movement, some problems may related to the pregnancy. Then duration of any problem, you should ask about the duration of this problem. So after the chief complaint, duration, you should ask this for every patient, this for every patient in the reproductive age group. You should think of pregnancy. You can't ask her, you know yourself you are pregnant or not. If she knows this, you have to ask her next questions. Now, tell me how many babies you have. What do you call the number of previous deliveries? We call parity. Always you should start the obstetric history with a gravida and para. What is the meaning of a gravida? A gravida includes the number of previous pregnancies and the present pregnancy. For example, if the patient is pregnant now, we will say the gravida, and parity, the number of deliveries after viability. What do you mean by viability? After either 24 weeks of gestation, or according to the American guideline, they consider it now, some guidelines after 20 weeks of gestation. So the first thing we will start after mentioning the chief complaint, gravida and para. For example, the patient has one baby, a live baby, and she has one miscarriage. And now she's pregnant. We will say gravida 3, para 1, plus 1. One miscarriage means, as I told you, pregnancy loss before viability. And viability, as I told you, either less than 24 weeks of gestation or less than 20 weeks of gestation. So this is something constant. Gravida, para, then we will ask the patient the other questions. Tell me now, you remember your last menstrual period? Last menstrual period, the first day of the last menstrual period. For example, the first day of the last menstrual period, 1st of November. So how you calculate the expected date of delivery? We will add 7 days for the days. 1 plus 7, 8. And 1st of, for example, November. And we will omit 3 months from the month. So 11 minus 3, she will deliver in August. So always LMP, expected date of delivery, and then period of amenorrhea. For the LMP, last menstrual period, expected date of delivery, sometimes if the patient has her last menstrual period or the 1st of January, in this case, how we calculate the expected date of delivery? We will add, we say 7, 1 plus 7, 8. January, in this case, January, we can't omit 3 from January. In this case, we will add 9 months for the month. So she will deliver 1 plus 9 on October. So she will deliver in October in this case. This is for how to calculate the month of delivery. Either you will add 9 months for the month or you will omit 3 months from the month. And for the days, for the days, for example, her last menstrual period on 25th of January, 25th January. How do you count the expected date of delivery? 25th plus 7, 32. But we have no 32. We will make it second. 25th of January, for example. 2nd of January plus 9, it will be on October, but we have an additional, so it will be 2nd of November. And this way, I will show you an example with the patient to how to count the expected date of delivery. So always last menstrual period, expected date of delivery. After that, we will have how far she's pregnant. How far she's pregnant. We will count how far she's pregnant, how many months she's pregnant. Or the period of amenorrhea, for example. Or I will show you the example how we can count the how far she's pregnant. But sometimes this is very important to remember. Not always the period of amenorrhea will be indicative of the time of pregnancy. In which condition? Sometimes the patient will tell you that I have amenorrhea of 5 months, but when you examine her, she might be 8 months pregnant. Sometimes the period of amenorrhea will be not indicative to the time of the pregnancy or period of gestational age, because either if the cycles are regular or not. So you have to ask the patient, this is another question. When your last menstrual period, before mentioning the expected date of delivery, you should mention the periods regular or not, or the cycle regular. You should ask her, you have regular cycles coming every 28 days. You are not on contraceptive pills, oral contraceptive pills, because oral contraceptive pills sometimes may cause amenorrhea, or some injection for contraception also may cause amenorrhea. So period of amenorrhea is not always indicative of the size of pregnancy. So now period of amenorrhea, we will mention it. Now we will return to analyze the present condition. We'll return to our complaint of the patient. She said, for example, I have abdominal pain or I have a bleeding. You have to analyze the symptoms. Describe the pain. There is a trauma. Complete history of the patient for the pain. Describe the symptom. Then what are the aggravating factors? What are the associated factors? And then what the treatment the patient received? What will aggravate this problem? And always you should not forget the fetal movement. Ask the mother about the baby and ask her about her condition. Don't forget the mother to ask the mother whether the fetal movement is okay or not, specifically when she is more than 5 months of pregnancy. When she is more than 5th month of pregnancy, you should ask her, and what about the fetal movement? Now also, in the history of present condition, you should ask her everything, what investigation done for you? You remember, they told you anything about the case, what they will do for you, what is the plan of your management, what the doctor told you. From this, you can reach to the diagnosis of the case. So until that moment, now they admitted you, when they will discharge you from the hospital, all this should be mentioned in the history of present condition. After history of present condition, we should mention the history of present pregnancy. These points should be mentioned all in detail. History of present pregnancy. You will start from the first trimester. What do you mean by first trimester? From the first diagnosis of pregnancy until 12 weeks of gestation. What are the important questions to be asked in the first trimester? You have a bleeding. This is for all cases. You have a bleeding. You have pain. They did for you ultrasound. You know ultrasound to be done to diagnose the age of gestation. You have severe vomiting or nausea and vomiting. This is in the first trimester. You started folic acid. This is for all cases you should ask. Then in the second trimester, after 12 weeks, you will ask her, you started the fetal movement. When you feel the fetal movement, when you have felt the fetal movement. Also, you have any bleeding, you have any complaint, and they did for you some blood tests, specifically a blood test for diabetic in the second trimester. And ultrasound, we call it fetal anomaly scan to diagnose fetal abnormality in the second trimester. In the third trimester, for example, if she reached to the third, after 28 weeks of pregnancy, you ask her, you have pain, How is the fetal movement? Is okay or not? You have no bleeding. You have no history of high blood pressure. You have no other problem. This is for the history of present pregnancy. Now we finish for the present pregnancy. After that, because this is obstetric case, we will mention the previous obstetric history. What do you mean by previous obstetric history? For example, one patient has one baby. You tell me about the history of present pregnancy. First trimester, as we mentioned, no bleeding, no pain, no excessive vomiting, and ultrasound, the same what we mentioned. Second trimester, the same thing we mentioned. Third trimester, and then we will ask her about delivery. Tell me about your delivery. It is normal or spontaneous or induced labor. We gave you drugs to stimulate labor. You have any complications after delivery like postpartum hemorrhage or any problem post-pyrexia, peripheral fever or peripheral sepsis after delivery? You have any problem after delivery? If she has miscarriage, we will ask her, they did for you curettage operation to remove the the product of gestation? You will ask her, you have no complications after delivery. This is for the previous obstetric history. Now, after obstetric history, we should ask her about the gynecological history, because this is a case of obstetrics. We should mention the obstetric history before the gynecological history. What the questions you will ask the patient and the gynecological history? Always you should start with the word menarche. What is menarche? The first menstrual cycle. You will ask the patient, tell me when your first menstrual cycle starts, at which age? For example, 12 years, 11 years. Tell me about your menstrual cycles previous. They are regular, coming every 28 days. There is no evidence of dysmenorrhea. Don't mention dysmenorrhea. You know what is dysmenorrhea? Pain on menstruation. Don't use these words. Dysmenorrhea. You have any severe pain on menstruation? You have the intermenstrual bleeding, bleeding between period. No intermenstrual bleeding, no postcoital bleeding, no pain or sexual activity. You have not received any contraception, no history of contraception. And tell me about your last menstrual cycle. It was normal or not? And always we should not forget you did pap smear or not. You know what is pap smear? This is a test to diagnose a pre-malignant condition, or what we call it intraepithelial neoplasia, which is a pre-malignant for CA cervix and not CA cervix. So all patients in the gynae history, we will ask them this question. Menstrual cycle, you have history of pap smear, you have any history of gynecological operations, not related to obstetric operation. Then we finish the obstetric history, we finished the gynecological history. Now we can ask her about previous medical and surgical history. What previous medical and surgical history which will affect pregnancy? We will ask her, you have no history of diabetes, no history of hypertension, you have no history of any other problem in the pregnancy like deep vein thrombosis or any problems affect the pregnancy outcome, specifically diabetes and hypertension, no history of congenital malformation, congenital abnormalities. After medical and surgical history, social problems. Nowadays, you can't ask her about domestic violence. Why? No history of domestic violence, because it is one of the factors which will affect the maternal condition, and it was one of the causes of maternal mortality. So ask her, you have no troubles in the family, not exposed to any problems. Then any history of drugs or allergy to drugs. These are the main important points in the history. This will be learned by practice, and you should have some checklist for these points so that you will not forget a point. Now I will start. I have one patient with me. We will start with the history for her. I will ask her some points, and then you will practice this. Even after finishing this session, you can, with everybody, with colleague, you can ask the questions, you can practice for the history. So I have my patient. I will start to take the history from this patient. Firstly, I will introduce myself. I am Dr. X. How are you?
I'm good.
Greeting of the patient is very important. If there is a female and you are a male doctor, better to bring female chaperone with you. This is in all the world. you have to practice this content, this thing. So how are you?
I'm good, ma'am.
I am Dr. Mawahib. I will ask you some questions.
No
Okay.
problem.
How are you?
I'm good, ma'am.
Okay. You can tell me your name, please.
Yeah, my name is Micaela, ma'am. I'm 35 years old.
Okay. You are Filipino.
Yeah, I'm from Philippines.
Yeah. And you are working or not?
Yes, I'm working, ma'am, as a receptionist.
Okay. You can tell me what brought you to what complaint? What's your complaint now?
I'm pregnant, ma'am. Then
Yeah.
I have mild abdominal pain since 3 days ago.
So chief complaint, always we will start with the chief complaint. She has mild abdominal pain for 3 days.
3 days ago.
Duration 3 days. After this, we will not consider as obstetric, or this is a lady for us. This is a patient. We don't know she's pregnant or not. She said she's pregnant. So once she says pregnant, I will start. Gravida, para, LMP, expected date of delivery. So you can't tell me now you are pregnant. So gravida. How many babies you have?
I have one baby.
You have one baby, and you have
one abortion.
Abortion. I prefer to mention the word miscarriage nowadays. Miscarriage is spontaneous loss of pregnancy. Abortion, miscarriage by itself. You lose pregnancy spontaneously.
Yes, ma'am.
So she is gravida in this case. Now she's pregnant, so we will say gravida. Gravida, she has one baby and one miscarriage. So she is gravida 3. Parity, she has one baby alive and she has one miscarriage. So we'll say she's para 1 plus small plus 1 miscarriage. Okay? If she has a previous dead baby, for example, also it will be included in the parity. If she has one baby died and only one baby, also we will say para 1. But no alive baby, for example. She has previous dead baby. If she has, so parity, the number of deliveries after viability. After 28 weeks of gestation, after 24 weeks, or some in American guidelines, after 20 weeks of gestation, some books say we consider. So this patient, gravida 3, para 1, plus 1. Okay, next questions, last menstrual period. You can tell me the first day of last menstrual period.
It was on January 4.
January 4,
2021.
21. January 4. So next step, expected date of delivery. January 4, she will deliver on 4 plus 7, 11. January plus 9, October. Okay, so she will deliver in October 2021. So she's pregnant. Now the next step, I have to find the period of amenorrhea or the age of gestation. As I told you, not always period of amenorrhea will be indicated of age of gestation. I will ask her these questions. Your cycles regular?
Yeah, it was regular.
Coming every 28 days and not on contraception? You are?
No.
You were not on contraceptive pills, not receive Depo-Provera injection?
No, ma'am.
That. So this how, now I will count the period of amenorrhea. How I will count the period of amenorrhea? We say she will deliver on, what is the expected date of delivery?
October 11.
October 11. Now, what is the date today? Today, 12 September. So how do you count the period of amenorrhea? Now I will tell you. If the patient in the last month of pregnancy for this like this patient, she will deliver only after 1 month. How I will count how far she is pregnant now? At the time of delivery for each patient, every lady, she will deliver at 40 weeks of gestation. 40 weeks of gestation. So at the time of delivery, 40 weeks. Now we are around 1 month near to her time of delivery. There is 1 month for her to deliver. So she's around 36 weeks of gestation. Is it clear or not? You omit from 40 weeks. At term, the lady will be 40 weeks. So we will omit how many weeks she's pregnant from this. She will deliver at 11 of October. And we are in September. We are 12 September, so one month is different. So she's pregnant 36 weeks of gestation. So period of amenorrhea or age of gestation, we call it 36 weeks of pregnancy. Next question. So now I know gravida, para, alampi, expected date, period of amenorrhea. Now I will return to analyze the symptoms. Now you tell me about your problem. We call it history of present condition. History of present condition. The first questions for the patient, for a pregnant lady, she's 36 weeks now, you say. For any pregnant, you will ask her, you have regular antenatal checkup? You have regular antenatal?
Yes, ma'am, I have regular.
You was informed to have any obstetric problem during the pregnancy?
Yes.
Like hypertension, diabetes, any? You haven't?
No, I don't have it.
From the beginning, I prefer to mention the important point in the beginning. So you will know that this patient is a high-risk condition. For example, she's pregnant, she has no history of hypertension. I will ask her, you have no obstetric problem. Now tell me about your present condition. What was the problem? Analyze the symptoms. Tell me about the pain, your pain.
Yeah, I have a lower abdominal pain.
Okay.
Yeah, for 3 days.
What is the character of pain?
Like a sharp pain.
The pain, either sharp pain or dull pain. Okay, she has sharp pain. Okay, tell me next. What about the pain? Coming every, how many?
Yeah, coming goes on.
Maybe it is labor pain. So any pain, you have to ask her for how long the pain is coming. For 10 minutes, for example. It's coming for the interval of pain. It's coming one time for 3 minutes, for example. For how long it is coming?
Maybe 10 to 5 minutes.
Okay, it is increasing with what?
Increasing maybe at around,
With rest, with working, with
no, especially when I was working. No.
any pain, ask about the trauma. You have history of trauma?
No.
No. You have history of with pain. Why there is pain? Might be urinary tract infection. Any problem in urine? You have urinary problem?
No, nothing.
Okay. You have any bleeding with pain? Any pain? Ask about the bleeding. You have a bleeding?
No bleeding.
Any pain? Ask about watery vaginal discharge in pregnant lady. It might be rupture membrane, rupture of liquor. So you have no watery vaginal discharge? No pain? No. What about the fetal movement?
Yeah, fetal movement is okay.
Any pain, any condition, as we mentioned, don't forget the fetal movement. Ask about the trauma, the bleeding, vaginal discharge, the criteria of pain. It's why you are concentrating on the pain. It's coming every 2 to 3 minutes because it might be labor pain. It might be labor pain. This labor pain, it is regular or not?
No.
Not. What you did for the pain? Any treatment was helpful for the pain?
No, ma'am. I took,
It is you have been admitted to the hospital?
No, not
for the pain?
No.
Any investigations done for the
yes, all investigation done. It was normal, ma'am. Especially
urine blood test was done for you or not?
It was done, ma'am.
Urine and the blood test. And what was the result of the blood? They told you have any problem in the...
The doctor told me everything was normal.
What about ultrasound?
Ultrasound?
You did?
Yes, ma'am. It's okay. Baby size is okay. Baby movement is...
Okay. Fetal movement is okay. Ultrasound. Important. What about the placenta? It is normally localized or
yes,
not?
ma'am. It's normal.
Okay. What did the doctor told you? She will admit you to the hospital or only treatment and investigation?
Oh, only the doctor told me for observation for 1 day to 2 days.
Now we finish with the history of pregnancy. Now you are better. How are you now? You are better? You are you feel better? After
yes, ma'am.
you received
better.
any treatment?
Yeah.
Now after the history of present condition, we will ask about history of present pregnancy. As I told you, first trimester, you have any bleeding?
No.
We will not say sorry first trimester in the early pregnancy month. In the first 3 months, you have any pain, any bleeding, any severe vomiting?
Only mild vomiting, ma'am. Yes, I have.
After 12 weeks, where the fetal movement was felt? You feel the fetal movement?
Around 5 months, I feel.
You feel the fetal movement?
Yes, ma'am.
Okay. And when ultrasound done, you have ultrasound for the fetal anomaly scan?
Yes, ma'am, was done already.
No problem for the baby?
No, everything was normal.
And after 28 weeks, what was any problem, any new problem except what you told us?
No.
No bleeding, no vaginal discharge, no pain. Okay. Tell me about your gynecology, previous obstetric history. You have First
And
baby?
the first baby, I was normal delivery.
Okay.
Everything was normal. Baby's weight is good.
The weight of the baby is important. And no history of postpartum bleeding or peripheral sepsis. Okay. And tell me about the second pregnancy. You said miscarriage.
Yes, miscarriage, ma'am.
At which month of gestation?
At around 12 weeks.
And they did the curita for you or not?
No, this is a
It
spontaneous.
is spontaneous and not. Okay. About we say previous gynecological history finished now. Previous medical and surgical history, no diabetes,
No, ma'am.
no hypertension, no any other medical problem.
No.
What about the social history? You have no history of some problems or
No,
nothing
nothing.
violent, and there is no history of any drugs. You are not on drugs
No.
or radiation. Thank you very much. These are the main points in the history. Okay, now the history, we completed the history. We completed the history. We will start with the clinical examination, with the obstetric examination. We will start with the obstetric examination. Now today I will concentrate on the obstetric examination. Of course, we should thank the patient. We should thank the patient and we should greet the patient for the help. Now for the obstetric examination. Today I will discuss with you the obstetric examination. But anybody asks you to examine any patient, you should not start with the obstetric examination. You should start with the general exam. Any patient, examine the patient. You should start with the general, but I would not. This is not our subject today. The general examination, vital signs, then local examination, head, neck, chest, abdomen. Today, our topic I will discuss on the obstetric examination. How to do obstetric examination for a pregnant lady. And of course, the obstetric examination, it depends on the age of gestation. This patient, for example, our patient 36 weeks, for example, we can examine the size of the uterus, we can see the direction of the uterus, the engagement, presentation. But if the patient, this will start from 28 weeks or 30 weeks of gestation. But if the patient is pregnant in early pregnancy, for example, 5 months, 4 months, 6 months, you can't determine the other thing, only the age of gestation. I will show you now. This patient is pregnant. This is the same patient we took history from her. Now I will take with clinical examination. The first point, I will introduce myself, and I will greet the patient. I will just, hello, how are you? I will just, excuse me, I will just examine your abdomen. I will try to make you not suffer for any pain. Will you excuse me? Excuse me for this? Yes. If the patient refuses, don't do clinical examination. The patient review. This is one. And always bring female chaperone with you for the male specifically. Even for the female, if you have another chaperone with you, better. The first step of now I will start with this patient. You remember the history, she's 36 weeks, for example. What is the first thing for clinical examination? I will ask her two questions before. Before touching the abdomen of the patient, I have to ask her 3 questions. Please, you pass urine? You should not examine a patient obstetric examination with full bladder, because the full bladder will give you a false impression on the size of the uterus. Don't examine patient with full urinary bladder. So ask her, please, you pass urine? If you did not pass urine, please, you can go to pass urine. This is one. Second thing, your hand. It should be the temperature of your hand. You should not hurt the patient. You should shrink your hand. You should not examine the patient with cold hands. You should not leave the patient to suffer for anything. So this is the second. And the third thing, you should ask the patient another questions. You have pain or not? You have abdominal pain or not? This is the most important. So please, you have pain, you pass urine, take the temperature. Now, excuse me, I will just uncover you and I will cover to see the abdomen. And I will cover the patient from here. You should cover the patient. And the other thing, which is very important, because I am now on the right side of the patient. You should be on the right side of the patient. Always the examiners, and most of the examiner, all the things, stand in the left side, in the right side. So tell you to come to examine the patient. Always be careful. You should not examine patient only on the right side, unless or you are left-handed. Okay, so always be on the right side of the patient and always keep the patient quiet. And then the next question. So you have no pain, you pass urine, the temperature of your hand, the first thing in your examination. On that, I am talking of the obstetric examination. I will examine the uterus in general. Don't examine like immediately, no. The first thing I have to examine, many students immediately from here examine the uterus. No. The first thing you should examine the uterus in general from the left side. You should examine the whole abdomen. Why? Why? Because why she has pain? What are the causes of pain at this age of gestation? Either labor pain, and in labor the pain is coming and going, contraction, relaxation. Or it might be what we call it placental abruption. This is bleeding inside the uterus, and there will be pain all the time. Or tender abdomen. This is the benefit of general palpation of the abdomen. Either to exclude tenderness. What is tenderness? She will, once I kept my hand, she will shout of pain because there is internal bleeding. The other thing in palpation, so this is wrong palpation I did. Why? I should look to the face of the patient. When I do palpation like this, I should not look to the abdomen. I should look to the face of the patient. I will do palpation. I will see she is really having pain or not. So don't do palpation and looking to the abdomen. Many students like this, do palpation. No, this is wrong. Always do palpation and look to the abdomen, to the face of the patient. So you understand the importance of general palpation. I will diagnose she's in labor, she's in placental abruption, she has internal bleeding or ruptured uterus. This is the importance. So the first thing is to examine general palpation. So general palpation, she has soft abdomen, she has soft uterus, not contracting, not tense. This is the important. Not contracting, not tense. 3 points I will diagnose by palpating the uterus. The next step, so general palpation. The first part, general palpation. Next step, I have to determine xiphoid process. You know the xiphoid process in the left hand. This xiphoid process with the finger, with the tip of finger. Why? Now I want to determine the age of gestation. I will keep my hand in the xiphoid process, and then I determine the xiphoid process, and then I will keep the ulnar border of the hand. The ulnar border of the hand to determine the fundal height. Where is the fundus? I want to determine some point with this. The age of gestation, for example, or the size of the uterus. How far? What is the size of the uterus in this case? I kept my hand here, but this is not enough to determine the age of gestation. I will bring the tape measure. This tape measure to determine the synphysio, what we call synphysio-fundal height. Synphysio-fundal height. This there are in centimeter and inches. You will look to keep the inches in your side so that it will not bias. There will be no biased picture. We'll keep the inches in front of us. And it is synphysio-fundal height. We will keep the 0 point not on symphysis, pubic symphysis. It is synphysio-fundal height. But to determine, I want to determine superficial-fundal height, but I will not keep 0 on the pupil surfaces. I will keep 0 on the when I felt the fundal height, for example, here. So like this is the inches in front of me. I see the inches. Then I will convert it into the centimeter. Now this centimeter, I will see here, it is around 36 weeks of gestation. So the first thing I will determine before the process, fundal height, symphysiofundal tape measure for symphysiofundal height, and then next step, I will check the fundal grip, fundal height, fundal grip. I will catch like this. I will see what is available in the fundus. It is normally the head will be down. We call it vertex presentation or cephalic presentation. So the breech will be here. Normally, I will feel when I catch the hand on the fundus, I will feel the broad, broad, soft, the breech, I will feel it here. So I will check the fundal height, fundal grip. Then I will do the lateral grip. Then below the umbilicus, lateral grip, fix one hand and move the other hand. Fix one hand and then move the other. I will fix one. I fix this and move this. And then I will move this. I'll fix this and move this. And then I will move this, I'll fix this. What is the benefit of this? What is the benefit of this? I will see which part, where is the hand? Where is the back of the baby? Because if the back here, for example, right occipital anterior, the right occipital on to see the occiput. So I will see the back and I will see the hand in this part, for example. Then next step. So I will repeat fundal height, fundal grip, lateral palpation. After lateral palpation, we call it pelvic grip. We have first pelvic grip and we have second pelvic grip. What do you mean by pelvic grip? What is the benefit? I will see which part is available in the pelvis, either the head or the breech, for example, or it might be transverse line. So in the pelvic grip, I will see, firstly, we have two parts, pelvic grip, first pelvic grip and second pelvic grip. First pelvic grip, I will see which part of the body is below, to be sure, this is the head. And then the second pelvic grip, I will catch one hand and see the engagement or to see the level of the head according to the pelvic brim. I will see the level of engagement of the head. So fundal height, fundal grip, lateral palpation, then first pelvic grip and second pelvic grip. These are constant. Every student should do it. Of course, at the beginning, we should say the uterus is soft or tender or tense. Then first fundal height, fundal grip, lateral grip, and lateral palpation, and first and second pelvic grip. What we should not forget, the most important part. I finished the examination? No. The mother will ask about the baby. I am doing obstetric examination not only for the mother. I want to see the baby's condition. So this is the penile fetal stethoscope. Is it clear? Penile fetal stethoscope. And we have another, we have sonicate. This penile fetal stethoscope to hear or to listen to the fetal heart. I will keep it if the head is down below, if the head vertex or below or cephalic, I will hear. I will listen to the fetal heart below the umbilicus here, for example, on the back. And this, is it clear or not? Here, it should be, I will listen to the fetal heart on the back of the baby below the umbilicus. If the patient has vertex presentation. Like this, I will hear to the fetal heart. Okay. If the patient has a breech presentation, the breech is here, the breech is in the lower uterine segment. When you will hear, where you will listen to the fetal heart, you will listen up above the umbilicus. In a breech presentation, we will listen to the fetal heart above the umbilicus. While in vertex presentation, you will hear the fetal heart here and below the umbilicus. Sometimes I do pelvic abdominal examination, and I didn't feel the head here. Normally, I'm talking about normal labor. What is the normal findings? They will tell me, I will tell you, or anyone, interpret your findings. So what you will mention, this is a pregnant uterus. The size of the pregnancy, 36 weeks, for example. It is soft, not contracting, not tender, containing a single fetus, longitudinal lie, vertical presentation, and the head is engaged or not. And the fetal heart is positive or not. Now, what is the meaning of engagement? Anybody will ask, why engagement? What? According to the abdominal examination, there is 5/5 rule. You will read it well. What is the meaning of 5/5 rule? Now we depend on 5/5 rule to determine the head is engaged or not, according to the obstetric examination of the uterus. What do you mean by 5/5 rule? 5/5 of the head. Part of the abdominal, you mean floating. So you say head is floating. 4/5 mean 4 part of the head is above in the abdomen. This means that fixing. 3/5, 3 part of the head only is in the is not in the pelvis. This is not engaged. 2/5 head is just engaged. 1/5 is engaged. What do you mean by engaged? Engaged, the most biparietal, widest biparietal diameter of the head enter into the pelvic berth. So this is a pregnant uterus, soft, containing a single fetus, longitudinal lie, vertex presentation, and the head is engaged or not, and the fetal heart is positive or not. This is, I am talking about normal findings. About normal findings. Of course, we should not, this is wrong from my side. I should not keep the patient uncovered. I will finish that, I will cover the patient. Thank you very much. You should thank the patient and cover the patient. We should take care of the patient. This is the most important. Thank you very much. I was talking about only normal obstetric examination. Thank you very much. And in the next sessions, we will start with the gynecological exam history, gynecological history and clinical examination, because the gyne history is different from the obstetric history. Thank you very much. Thank you. This will come with the practice. How much cases you examine, you will examine, you have the good practice in a clinical examination. And the history is very important. You will build your life, you will build yourself with taking good history for the patient. You will know how to communicate with patient. Thank you very much.